When we look at this movement of gases, what we end up looking at is we end up looking at volumes of inhalation and exhalation, or how much can the lungs expand during inflation. The lungs will hold anywhere from about 3/4 of a liter, 0.75 liters, or 750 milliliters, up to about 6 liters at full inhalation. The difference between those two numbers is referred to as the depth or the volume of the respiratory cycle. What you remember is that the interactions of pleural linings will ensure that we have a resting or a residual volume within the lungs at all times to keep the lungs inflated even in between inhalations and exhalations. What is important to remember here is that the lung volumes are highly modifiable and that the total lung capacity has an anatomical maximum even though the lung volumes are highly modifiable. So what are the things that are going to influence that maximal capacity? Well, thoracic shape is going to influence the maximal capacity. The size of the person will influence the maximal capacity. Because the size of the person will influence the maximal capacity, gender may influence that. Given that men typically are slightly larger than females, a male will have, in general terms, a larger maximal capacity than a female. However, equal-sized people will have equal volume maximal capacities. The last thing that's going to influence this maximal capacity is fat distribution, where fat distribution, particularly visceral fat, will act as an anchorage, changing the thoracic shape. Additionally, people based off of where they have their heritage in terms of evolution will have different thoracic shapes. People who come from higher levels of elevation in terms of evolution heritage will have a larger thoracic shape and therefore have larger maximal capacities for their lung volumes. It's an evolutionary advantage that these people developed in order to survive at higher altitudes. Now, what about the factors that are going to influence the lung volumes? Most of these are modifiable, whereas the maximal capacities are anatomical limitation. These include, once again, the thoracic shape. The thoracic shape here, we're not talking about the anatomical evolutionary thoracic shape. What we're talking about is we're talking about how does the thoracic shape change based on things such as laxity of abdominal sheath. The laxity of the abdominal sheath is due to the fat distribution, in particular, visceral fat relation in between the abdominal muscle and the connective tissue, the omentum, that surrounds the internal organs. Once again, gender will come into play here. Level of activity, where the person who is more active will have greater functional volumes and will be closer to their anatomical maximal capacity than people who are inactive at all. People who have a history of smoking will have a change on their potential maximal volumes. The other thing that smokers will have is damage to the cilia. And it's not just smokers, it's anybody who gets exposed to hot air temperatures, where because of the protein structure within the cilia, the heated air can cause denaturing of the proteins. The denaturing of the proteins leads to the cilia not functioning correctly and the inability to expel whatever pathogenic material is being trapped by the secretions within the trachea and within the bronchioles. Other things that might influence this is disease states such as asthma, bronchitis, COPD, and emphysema. So how do we look at these lung volumes? Well, one of the ways that we look at these lung volumes is based off a spirometric readout, like what we see here, where on a normal inhalation and exhalation, we get what's referred to as tidal volume. Tidal volume is what I normally breathe in and breathe out at rest. It's typically averaged to be about 500 milliliters of air movement at a given time. If we inhale past what we're able to normally inhale at, we get to what's known as the inspiratory reserve volume. The inspiratory reserve volume is how much additional air I can inhale beyond what I normally do. And that is typically normed to be about 3 liters or 300 milliliters, 3,000 milliliters. And then we get the expiratory reserve volume. That is how much more I can exhale beyond what my normal breathing happens to be. This is what we usually use when we're going to, say, blow up a balloon or blow out birthday candles. This is given at about a norm value of 1,500 milliliters or 1.5 liters. If I total all of those volumes up, I get what's referred to as the vital capacity. Vital capacity is how much can I maximally exchange within one single ventilatory cycle. This is normed to be about 4,200 milliliters or 4 liters. Then I have my residual volume. That's the amount of air that will constantly stay within the lungs due to passive airflow and retention within the lungs that keep the lungs inflated at all times. This is about 750 to 1,000 milliliters. If I total all of those up, I get what's referred to as total lung capacity. That is the sum of all of these lung values that we have looked at. Basically, total lung capacity is vital capacity plus residual volume. For the people who are highly active, vital capacity is going to have the largest swing of all of the values. Residual volume will stay constant. Expiratory reserve volume might elevate slightly, but the biggest change we see is with the inspiratory reserve volume. So let's take a look at the pathway of airflow. What we have to remember is that we're going to have bidirectional flow, and the bidirectional flow is based off of volume, gas loss, muscular activity, and compliance of the tubes, where we have flow in from the atmosphere through the pharynx, into the larynx, through the trachea, into the bronchioles, and then finally into the alveoli, where we have gas exchange. Then we have flow backwards, going from the alveoli, through the bronchioles, into the bronchi, to the trachea, to the pharynx, into the atmosphere on exhalation. In this pathway of flow, we will have 3 distinct locations for air exchange. The external exchange is going to be between the alveoli and the atmosphere. And then we have internal exchange. And there are 2 distinct areas of internal exchange. The first area of internal exchange is between the alveoli and the capillaries. And then the second area is between the capillaries and the tissues. And we'll take a look at these exchanges based off of movement of gas due to the distinct gas laws that are going to dictate where gases move and how quickly they move.